Hi, I'm going to talk about the ustekinumab induction and maintenance therapy in the refractory Crohn's disease. Okay, the ustekinumab is a drug. This is a drug that belongs to the group of the monoclonal antibodies and used in the treatment of psoriasis. It works by blocking the actions of certain cells in the body that cause the symptoms of psoriasis. The administration, the presentation of the ustekinumab is an injectable solution for subcutaneous disease under the skin. This is usually administered for the nurse or the doctors. This is every 4 weeks for the first or 2 doses, and then every 12 weeks. Okay, in the patients with Crohn's disease, the efficacy of this drug ustekinumab, the human monoclonal antibiotic against interleukin 12 and interleukin 23 is unknown. Okay, but patients with moderate to severe Crohn's diseases that was resistance to TNF antagonists had an increased rate of the response to inductions with ustekinumab as compared with placebo. The patients with an initial response to ustekinumab had significantly increased rates of the response and remission with ustekinumab as maintenance therapy.
The study Peace Summit has 2 separate studies, Peace Summit 1 and 2. It's a study of ustekinumab in psoriatic arthritis. Ustekinumab is approved in the United States and in other countries for the treatment of skin psoriasis, and these are large phase 3 studies in psoriatic arthritis. At this meeting, Professor Chris Richland presented updated data from Peace Summit 2, showing the data in focusing on people who had been on TNF inhibitors previously, showing that you do get clinical response in terms of the signs and symptoms of psoriatic arthritis, and also good response in skin. The important point of this is that as we treat patients with psoriatic arthritis, we'd like to have additional therapies. We have available some traditional therapies, biologic agents, mostly the TNF inhibitors, so it's good to have additional choices for people. Ustekinumab has been approved for the skin psoriasis, and our dermatology colleagues are using it, and this data says that it may be useful for the rheumatologist to consider as they see patients with psoriatic arthritis.
So is there any future, you think, for moving this through the regulatory pathway to become an approved indication?
Well, I think we would hope so. As a clinician, I would hope so. As a researcher, I think that that's the point of doing these sorts of large studies, and I do think that the company will try to move forward to get full approval so that we can more easily get it for our patients with psoriatic arthritis.
Is Peace Summit enough to base an approval application on?
Well, it's a regulatory question. It was designed so that hopefully it would satisfy the requirements, and I think the sponsor's anticipation is that it should be, or hopefully will be.
Psoriasis is a chronic immune-mediated disease affecting 0.1 to 0.05% of the population in the People's Republic of China. The treatment of psoriasis has become an increasingly serious issue in public health. Biological agents for psoriasis therapy introduced into mainland China only in recent years, but they have already shown their superiority compared to the non-biological therapies. In this essay, we focus on biological agents, especially ustekinumab, which is a new biological agent for the treatment of moderate to severe psoriasis, demonstrating the advantages of good efficacy, long duration of action, and good patient tolerance. It has finished phase 3 clinical trial will be available in mainland China in 2014. Meanwhile, at the high prevalence of hepatitis B and tuberculosis in mainland China, the long-term safety and efficacy of ustekinumab still need further investigations.
Okay, the Crohn's disease. The Crohn's disease is a chronic disease of unknown origin that may have an autoimmune component in which the individual's immune system attacks its own intestines, causing inflammation. Often the affected parts in the final leg of the ileum or small intestine. Also, the disease can occur anywhere in the digestive tract. Okay, the exact origin of the disease is known, but is known about genetic and environmental factors that increase the risk nature of suffering. Several studies have associated the disease to genetic variants, including a hint of chromosome 16, but these not strictly hereditary diseases.
Welcome back to the IBD School Basic Series. In this episode, IBD School 102, we answer the question, what is Crohn's disease? And explain the different forms of inflammatory bowel disease. Inflammatory bowel disease, or IBD, is a disease of long-lasting or chronic inflammation of the gastrointestinal tract. Inflammation is a result of activation of the immune system, and it generally includes 5 signs of active inflammation: warmth, redness, pain, swelling, and loss of function. In IBD, these symptoms happen in the gastrointestinal tract and cause symptoms in your belly. We refer to IBD as a chronic inflammatory disease because the immune system is abnormally activated and stays activated for months or years. The inflammation can quiet down or become quiescent for a while, but weeks, months, or years later, the inflammation can come back with a big flare of activity and symptoms. It is also chronic because the damage or distortion of the intestine lining is left behind when the intestine heals after a flare and can still be seen under a microscope. Crohn's disease causes inflammation throughout the entire thickness of the wall of the GI tract. This affects all of the layers of the wall. Because it goes across the whole wall, Crohn's is called a transmural disease. Crohn's disease can cause inflammation in any segment of the GI tract, from the mouth to the anus. The most common place for Crohn's disease to start is the terminal ileum, the last part of the small intestine, just upstream of where the large and small intestines meet. This is one of the most narrow parts of the GI tract, which can cause problems later on. Crohn's disease is also segmental, which means that one part of the intestine can be affected, while segments of the intestine just upstream or just downstream of the affected segment appear completely healthy, even when small biopsy pieces are examined under a microscope. People with Crohn's disease can be affected in different locations in the GI tract. About half are affected in both colon and small intestine, about 30% in just the small intestine, and about 20% in just the colon. About 10% of these people are also affected further upstream, in the esophagus, stomach, or the beginning of the small intestine. The symptoms that usually have the most impact on patients with Crohn's disease are abdominal pain, tiredness, increased bowel movements, nausea, bloating, fevers, joint pains, loss of appetite, and weight loss. These fairly vague symptoms can make Crohn's disease hard to diagnose, and it is not uncommon to have symptoms for a few years before the correct diagnosis is made. Two other diagnoses that are not IBD are important to know about. One is acute infectious colitis or acute enteritis. These are due to inflammation of the colon or small intestine that lasts a short time, days or weeks, and then goes away. These are generally due to infections and don't leave any chronic damage behind afterward that can be seen under a microscope. Sometimes people with acute infections of the GI tract are thought to have IBD, but turn out to have just had a bad infection of part of the GI tract. Another diagnosis that is not IBD is IBS, or irritable bowel syndrome. IBS can cause symptoms of pain, diarrhea, or constipation that can look like IBD, but there is no chronic inflammation and damage to the lining of the intestine. However, the abnormalities in IBS and the inflammation in IBD are treated very differently. That's it for this class, and thanks for watching.